We have a 62-year-old lady with pancreatic cancer diagnosed 2 weeks ago. We started her on Lortab, but unfortunately it did not help her pain. During last examination by EUS and by CT scan of the abdomen, there is clear evidence of involvement of the celiac artery, and therefore she's not amenable for surgical evaluation and surgical resection. We counseled her regarding the need for celiac plexus neurolysis, and she's here today to undergo that procedure. Many studies published to date suggest that endoscopic ultrasound guided celiac plexus neurolysis is really helpful in this setting, since it leads to success in about 70 to 80% of the patient. It's a safe procedure, is performed on outpatient basis under conscious sedation. Here we have given our patient low dose of Demerol and Versed, and we use some ketamine as an adjunct to sedation. Typically, we insert the echo endoscope to the level of the celiac artery. The echo endoscope is inserted in the patient's esophagus. It was a smooth intubation, and when we are at about 35 centimeters from the incisors, we switch to ultrasound. And the landmark we look for is really the descending aorta at about 35 to 40 centimeters from the incisors. The descending aorta is a tubular organ, as you see here with Doppler, color Doppler ultrasound. Once you identify the aorta, you push forward with the echo endoscope till you find the first branching artery, and that's the celiac artery. To confirm further, it will be nice to demonstrate the superior mesenteric artery, as you could see in this image. Back to back. This way you are sure that you are performing the celiac neurolysis in the right area. This is the anatomy here. You see the celiac artery in this area. Superior mesenteric artery is here. And in a moment, we'll show you the descending aorta at this level. Also, for confirmatory purposes, we perform color Doppler sonography to identify further the celiac artery and to ensure that there are no intervening vessels in the way. The arrow actually is a good location and estimation where I need my needle to be. I'm currently using the CPN fenestrated needle. It's a 20 gauge needle. I think the advantages are clear with using it. In comparison to the 22 gauge needle, I think we can do a quicker and faster injection. Okay, I think I crossed the wall of the stomach here, and then we're going to aspirate to ensure we don't have any blood return.
Aspirating, injecting.
We're performing the injection. Again, it's all at the tip of the arrow. You see the needle in place, and that actually created a nice cushion for us to inject the alcohol. Now here we better be sure about the needle placement. Go ahead and aspirate. Since the alcohol will create a hyperechoic shadow that will block our view, as you'll see in this image. Okay? As you see, that the injection is really quick with this fenestrated needle. We use the bupivacaine 0.25%, 6 cc's, and we injected 20 cc's of absolute alcohol in this area. We withdraw the needle from the scope. And at this time, the procedure is terminated.